why is it that in Newton-Bakers you are expected to calculate only the planimetered area and not the Dopplers? Anybody? Why can't you trust the Dopplers?
Because the LA pressures are dissipated across the ASD.
So if a truthful surgical valve area is 1 in a Newton-Bakers, you put pressure half time across mitral, how much will it record?
1.5, 1.6.
Wonderful. So there is a truthful mitral stenosis, intact septum, severe mitral regurgitation. Truthful valve area is 1. In a severe mitral regurgitation, what will the pressure Doppler respond? Pressure half time. 0.8, 1, 1.5. Mitral stenosis with severe mitral regurgitation.
0.8 overestimation because of
Why?
more flow. More flow every diastole. That's why.
Lovely. So anybody who's not able to understand, we are going quick, but we have enough and more time. We can pick up the discussion. Anybody who doesn't understand this discussion, please, we'll be very happy to discuss it because it's the hemodynamics. Romance of echocardiography is in hemodynamics. So in case there is somebody who's not able to understand, please raise up your hand shamelessly and we'll be very happy to discuss it. Aortic regurgitation and mitral stenosis, what will it record as? 0.8, 1, 1.5. The question remains the same. Planimetered area is 1. If there is a severe aortic regurgitation, what will it record as in pressure half time?
1.5.
1.5. Anybody else who agrees or disagrees with him? Till now, he has not been wrong. Louder, louder. Come to the mic, doesn't matter. It will remain 1. 0.8.
It can vary actually. There are two principles. If the AR jet is actually impairing the mitral valve opening, then
wonderful. So it can be 1.5 or it can be 0.8
also,
depending upon which direction the AR jet is hitting.
Yeah.
If it is hitting the AML and it is preventing its opening, it will record 0.8. If it is a central jet, there is a very quick increase of left ventricular end diastolic pressure. So the LA and LVDP difference comes very quickly down, and that's the reason why you can have a 1.5 area. Okay, what else is left? Mitral stenosis with severe aortic stenosis. 0.8, 1, 1.5.
1.5.
1.5. Everybody's understood 1.5? Because the LVDP is increased, so LA to LVDP pressure is already low, so the gradients will be much lesser. Okay, now for this. Who's going to answer this?
Do the videos play, sir? Caudal rupture of the AML with AML prolapsing into LA severe MR.
AML prolapsing, flail. Flail AML, acute mitral regurgitation. Disastrous condition. Sent to the surgeon. Ayo, it doesn't play. What is the problem? It shows here. Why is it not showing there? The moment it starts playing, it disappears. This is sabotage. Which one? Inge? This one? I don't know. It shows here though. Can you adjust it? It is showing here, but why does it not show there? Do some displays. Okay, let me, whichever are the ones which you can see, you see. I can see them very here. Let me just get out of it first and then play it. Now it shows? No. Now it shows. Sorry. I think this is hint for me to say shut up. No, I think something is okay. Let me just get out of it first. Let me just get out of many of my presentations. Sometimes these also interfere. No, it doesn't show. Anyway, try to make some sense of it. There is a nodule here. What is it? Sorry. So this is a papillary fibroelastoma. What is the implication of this? So when you start analyzing young strokes, you'll find more of papillary fibroelastomas. But when you start following papillary fibroelastomas, they don't cause strokes. So people don't know because there is some bit of an association, but to prove a risk, to prove an association beyond marker, you have to have three things in statistics. One is a positive correlation, second is negative correlation, and third is in incremental value after uh, intervention. So in this case, when you look at young strokes, you will find more of papillary fibroelastomas. But when you follow up papillary fibroelastomas, they don't stroke. And the world is still debating, since you don't have positive or negative correlation, should you attempt for the third one, that you take out these fibroelastomas, change the valve or do whatever, and then it will further. So we are still not sure, but most of the people will give antiplatelets for whatever worth it is, not that it is indicated. Sorry, my computer doesn't work. Let me just try to find out if I can dig out some more presentations. Otherwise, we'll call it a day. Let me just try if this works. Okay, one more. Tell me when to keep quiet, sir. 20 years old boy referred for surgeon for hypertrophic obstructive cardiomyopathy and LVOT obstruction. Diagnosis. LVOT obstruction, yes, no, yes, no. Where is it? So are you convinced that there is no hypertrophy of the left ventricle? So I'm happy that uh, doctor, what's your name?
Dr.
Pritam. Be a little merciful to the histopathologist. Don't make histopathological diagnosis on echo, even if you think you are correct.
That being the most common, I suggested.
No, no, no. Okay, let's see more. So he has picked it up fine that there is something which is looks like a tumor in the LVOT. And what is this LVOT tumor? We'll keep figuring out, but LV is certainly hypertrophed. And if you look at this, this is something which is worrisome to me, because this tumor is in the LVOT, yes, but there is something which is happening all over this place. This is something which doesn't look good to me. Whether it is non-compaction, whether it is hypertrophic cardiomyopathy, whether it is tumor extension, I am not too sure. So we'll see more. Now let's look at it more. See this? And keep looking at this tumor here. Now, you think it is myxoma? You've already made a histopathological diagnosis. No, sir. I'm talking about the apex. This is this tumor is attached to the AML. He is correct, which is obstructing into the left ventricular outflow tract. But certainly it is not from the LVOT muscle from the septum. We have some more pictures. We'll see more. So this is transesophageal echo because we wanted to show. So here is a tumor. I'll stop it somewhere so that it, and somebody, if they can make a diagnosis, I'll be very happy. Okay, more pictures. Maybe it's not convincing. Now, diagnosis.
Multiple hydatitis.
Lovely. So this is a cystic structure where there is a cartwheel which is flowing all around, and we potentially made a diagnosis of cystic mass, and we did send this person for surgery. See this. And I did actually tell the surgeon that be careful. This is because whenever you are operating upon hydated, the surgeon has to be very careful because there should be no spillage. No spillage means no spillage. And when we got him operated and we lost him, and histopathological diagnosis was studied with hydated. This was the diagnosis. So we lost this boy. Okay. More to come, or shall we finish it? Okay, one more case. Whatever you insist. Simple ones. Sorry. Somebody volunteer to see and suggest. Nothing great. Nothing great. Nothing great. What is it? Something has gone wrong. The computer doesn't move further ahead. I don't know, but it looks to be a large. Why is this not a pseudoaneurysm? It is a true aneurysm, but why is it not a pseudoaneurysm? This view, and do you think that it is a pseudoaneurysm or a true aneurysm? How do you differentiate true from pseudoaneurysm, and what is the implication? Should you try to differentiate, or should you just sit on it? Anybody? Sir?
Typically, we look at the neck.
So this is the neck,
Yeah, this is the
and
neck.
this is the width.
Yeah, if you see, the other thing is, as you are playing the thing, you don't see the neck is very narrow. Neck is reasonably wide in a true aneurysm. True aneurysm, neck used to be narrow with a thing, and of course, Doppler will be a to and fro. And you look at the akinesia of those segments completely, or there may be a very patchy areas of hypokinesia.
So we were a little confused because in this case, there is a ledge of tissue
Yeah,
and the neck doesn't seem to be too wide.
not too narrow.
So this is falling into a place where there is a confusion. And don't sit on this confusion thinking that it is a true aneurysm. So you leave it because this could well be a pseudo aneurysm. And this is the place where you have to go for multimodality imaging and MRI comes in best. In any case, this was the off axis or the unconventional views because of which you found that there was a huge big thrombus sitting there along with. But it is not that in pseudo aneurysm you don't get aneurysms at all. So I'll finish it off here. I'm sorry, my computer kind of gave way, but thank you very much for your patient listening.